Welcome to the deep dive. You know, when we talk about cardiovascular health, our minds often jump straight to headline-grabbing issues like heart attacks or strokes.
Yeah, those are the big ones everyone knows.
Exactly. But what if I told you there's a quieter, often insidious threat? One that's growing increasingly common with age and impacting millions around the globe, yet it rarely gets the same spotlight.
Sounds intriguing. What are we diving into today?
Today, we are taking a truly deep dive into aortic stenosis, or AS, which happens to be the most common valve lesion we encounter in adults.
Aortic stenosis, right? A really important topic. Our mission today is to go far beyond the typical explanations you might find, to truly pull back the layers and understand aortic stenosis with the kind of depth an elite professional would demand.
So really getting into the weeds.
Absolutely. We're going to unravel its intricate origins, how it progresses, the subtle signs it might present, the precise ways we diagnose it, and the cutting-edge treatments available now. We've pulled together a substantial stack of sources for this deep dive, with our primary focus being Chapter 261 from a comprehensive medical text.
Okay, Chapter 261 it is.
We're going to extract every single important nugget of knowledge from that material.
And so, whether you're looking to quickly get up to speed on a new field, perhaps prepping for a critical meeting, or maybe you're just incredibly curious about how the heart works and what can affect it, we're here to give you that essential shortcut.
Get you right up to speed.
You'll walk away truly well-informed, and we promise to give you plenty of those aha moments along the way. Let's get started. So let's open this up. When we consider major public health challenges, valvular heart disease doesn't always spring to mind first. Our attention often gravitates towards things like coronary artery disease, stroke, hypertension, obesity, or diabetes.
Right, the usual suspects.
But what our source material makes abundantly clear is that while valvular heart disease might rank below those in some measures, it's still a profoundly significant cause of morbidity and premature death, especially when we look at the global landscape.
It's a crucial distinction, definitely. And the global burden truly is immense, with stark disparities from one region to another. What's fascinating, or perhaps alarming, is that rheumatic heart disease, or RHD,
Okay, RHD.
which originates from rheumatic fever itself, a consequence of untreated Group A, streptococcal pharyngitis, is unequivocally the dominant cause of valvular heart disease in low- and middle-income countries. This isn't just a minor issue. It's widespread.
Really dominant, you said.
Oh, yeah. The prevalence figures we see in the source vary wildly, from as low as maybe 1 case per 100,000 school-age children in places like Costa Rica to an astonishing 150 per 100,000 in China.
Wow, that's a huge difference.
It is. And this isn't merely academic data. These numbers translate into significant real-world impact, accounting for anywhere between 12% and a staggering 65% of hospital admissions related to cardiovascular disease, and 2% to 10% of hospital discharges in some of these endemic countries. The scale is truly sobering.
That's a huge range, and it really underscores how localized these conditions can be. What else contributes to this stark global disparity you mentioned?
Well, in economically deprived tropical and subtropical areas, the progression of valvular disease is alarmingly rapid. It moves far more quickly than what we typically observe in, say, developed nations.
Faster progression.
Much faster. We see patients developing serious symptoms before they even turn 20, which is a stark contrast. This accelerated natural history is believed to be linked to repeated infections with particularly virulent strains of rheumatogenic streptococci, essentially a more aggressive form of the initial infection.
So repeated hits from nasty bugs.
Pretty much. And globally, the statistics are quite staggering. An estimated 30 to 35 million people are currently living with RHD, with approximately 300,000 new cases diagnosed and 233,000 fatalities occurring each year.
That's a huge number of people affected.
It is. The highest prevalence and age-adjusted mortality rates are concentrated in sub-Saharan Africa, South Asia, and Oceania. And what's driving this? Fundamentally, it boils down to reduced access to high-quality health care and underlying social determinants of health that contribute to untreated streptococcal pharyngitis in these endemic areas. It's a systemic, deeply ingrained problem.
So if the global picture shows an overall decline in mortality from RHD, does that mean we're making significant progress against it? Or is there more to the story?
Here's where it gets a little paradoxical, and this is a key insight. While the age-standardized mortality rate from RHD globally did decline by nearly 50% between 1990 and 2015, which, on the surface, sounds like great news.
Yeah, sounds positive.
The prevalence of heart failure specifically attributable to RHD increased by nearly 90% over that very same period.
Increased. How does that work?
What this tells us is that while fewer people might be dying from the acute, immediate complications of RHD, a much larger number are living longer with its severe, debilitating long-term consequences, often ending up with chronic heart failure.
Ah, I see. So they survive the initial phase, but live with the damage.
Precisely. Even in the United States, which is a high-income country, RHD tragically accounted for 3,320 deaths in 2017. So the burden isn't just mortality, but a significant and growing chronic illness.
That's a powerful point about the long-term burden of disease. So shifting our focus now to high-income countries like the US, what then becomes the dominant cause of valve disease if it's not primarily rheumatic heart disease?
Right. In high-income countries, the landscape changes dramatically, largely due to demographics and lifestyle. Here, valve disease is predominantly caused by degenerative or inflammatory processes.
Degenerative, like wear and tear.
Sort of, but it's more active than just passive wear. These processes lead to a gradual thickening, fibrosis, calcification, and ultimately dysfunction of the heart valves. And critically, the prevalence of valvular heart disease increases significantly with age.
Okay, so it's an age thing primarily here.
Very much so. Our source points out that around 6% of individuals over 65 years old have undiagnosed moderate or severe valvular heart disease. This figure rises even higher for those over 75, where significant left-sided valve disease can affect as many as 12% to 13% of adults. So it's a major age-related phenomenon in these regions.
That's a significant percentage of the older population facing this. And specifically for aortic stenosis, our main topic, how prevalent is it in this context?
Severe aortic stenosis, or AS, is estimated to affect approximately 3.5% of the population over 75 years of age.
3.5% over 75. That's still quite a few people.
It really is. And to give you some context on the broader picture of newly diagnosed valve disease, a Swedish epidemiological study found the incidence of new valvular heart disease diagnoses at 64 per 100,000 person years.
Okay.
In that study, AS and mitral regurgitation were the leading culprits, with AS contributing about 1/2 and mitral regurgitation about 1/4 of all new valvular heart disease diagnoses. So while other conditions exist, AS is clearly a major player, especially as populations age.
Got it. So besides RHD and age-related degeneration, are there other important causes we should know about?
Yes, another significant and unfortunately increasingly relevant cause of valve disease is infective endocarditis.
Infection of the heart valve itself.
Exactly. The incidence of this condition has seen an unfortunate rise for a confluence of reasons. We're seeing an aging population overall, a more widespread use of vascular grafts and intracardiac devices in medical care, the emergence of more virulent and multi-drug-resistant microorganisms that are harder to treat.
Nasty bugs again.
Right. Plus the growing diabetes epidemic and sadly the opioid crisis, which leads to increased intravenous drug use and associated infections.
A perfect storm of factors, it sounds like.
It really is. While there was some concern that more restricted use of antibiotic prophylaxis since 2007 might increase incidence rates from oral bacteria, this hasn't been definitively linked. What's absolutely clear, though, is that infective endocarditis has become a relatively more frequent cause of acute valvular regurgitation, meaning the valve suddenly leaks severely.
Acute leakage. That sounds serious.
Very serious. And about 50% of hospitalized patients with infective endocarditis will undergo valve surgery during the acute phase of their illness, highlighting its severe and often rapid impact.
That makes sense as more people live longer with complex medical conditions. And what about congenital heart defects, like the bicuspid aortic valve? You mentioned that earlier. Where does that fit into this global picture of valvular disease?
Right, the bicuspid aortic valve, or BAV, it affects a notable portion of the general population, somewhere between 0.5% and 1.4%. What's particularly important here, and this is another aha moment, is that BAV disease isn't just about a malformed valve with 2 leaflets instead of 3.
Okay, what else?
It's often accompanied by an associated aortopathy in about 30% to 40% of individuals.
Aortopathy, meaning disease of the aorta itself.
Precisely, disease of the body's main artery. This can manifest as root or ascending aortic aneurysm formation, a ballooning of the aorta, or even descending thoracic aortic coarctation, which is a narrowing. We're also seeing an increasing number of childhood survivors of complex congenital heart disease now presenting later in life with various forms of valvular dysfunction.
So the problem extends beyond just the valve.
Often, yes. This evolving demographic means the global burden of valvular heart disease in its entirety is only going to continue to progress and demand our attention.
So even with all these medical advancements, are there still significant disparities in care for valvular heart disease, especially in regions that need it most?
Without a doubt, disparities in both access to and quality of care for patients with valvular heart disease are unequivocally well documented. This is particularly acute for RHD patients in low and middle income countries where the challenges are systemic and overwhelming.
But what about here in high-income countries?
It's important to realize it's not solely a global South problem. Even in high-income countries like the United States, our sources point to concerning trends. For example, in the STS-ACC TVT registry, Black individuals comprise less than 5% of patients in the United States who have received a transcatheter valve for aortic stenosis.
Less than 5%. That seems low.
It is. This highlights that factors like age, sex, race, and geographic location continue to significantly influence management decisions and patient outcomes. It's a clear call for intensification of educational efforts, for conscious prioritization of resources, and for systemic changes to address these persistent inequities.
So what does this initial overview truly mean for us? It means understanding valvular heart disease, and specifically aortic stenosis, isn't just an academic exercise.
Not at all.
It's crucial not only for the individuals directly affected, but also for global health, demanding a truly comprehensive understanding. The scope is broad and the impact profound. Let's really drill down now into aortic stenosis itself. Aortic stenosis is the most common valve lesion among adults with chronic valvular heart disease, and it predominantly affects males. But what exactly causes it? Is it just simple wear and tear as we age, or something more complex and active?
That's a critical question, and our source, specifically Table 261-1, breaks down the major etiologies, or causes, of AS in adults. The most common cause is indeed degenerative calcification of the aortic cusps. But here's the key insight. It's not just a random accumulation of calcium.
Okay.
This calcification typically occurs on an underlying substrate that predisposes the valve to this process.
So what kind of underlying conditions are we talking about that set the stage for this calcification, like a foundation for the problem?
Exactly. The primary substrates include congenital disease, particularly a bicuspid aortic valve, a valve born with only 2 leaflets instead of 3.
We talked about that one.
Right. And accounts for a significant 53% of surgically removed valve specimens, highlighting its prevalence. Then there's chronic deterioration of a normal trileaflet valve, which is closer to what we think of as age-related wear and tear over many decades.
The standard 3-leaflet valve just wearing out.
Essentially. And finally, previous rheumatic inflammation, as we discussed earlier with RHD, can also set the stage for calcific AS, although it's less common in high-income countries, maybe around 4% of unicuspid valves seen in specimens. So while calcification is the mechanism, the underlying valve structure or its history often plays a decisive role.
Makes sense. Are there causes beyond calcification?
Yes, beyond calcification on those substrates, rheumatic fever itself can directly cause AS. It does this by producing commissural fusion.
Fusion, like the leaflets stick together.
Exactly. Fusing the leaflets together at their edges, which then makes them more susceptible to trauma and eventually leads to fibrosis, calcification, and narrowing. This form of AS is almost always associated with involvement of the mitral valve as well, and often with aortic regurgitation, a leaky aortic valve.
So RHD causes a double whammy sometimes.
It can. Lastly, radiation exposure, particularly mediastinal radiation, which is radiation to the chest, can lead to late scarring, fibrosis, and calcification of the aortic leaflets, causing AS as a long-term side effect, sometimes years or decades later.
That brings us to a fascinating point. This calcification process, is it just a passive accumulation of calcium like rust on a pipe? Or is it a more active biological process?
Yeah.
Our source emphasizes it's decidedly not passive.
That's right.
And that it shares many features with vascular atherosclerosis, the process that hardens our arteries. Can you unpack that connection for us? This feels like a big aha moment.
This is truly where our understanding of AS has evolved dramatically. And it is indeed a huge aha. Aortic valve deterioration and calcification is an active disease process, not just passive wear. It mirrors, in many ways, the process of atherosclerosis that occurs in our arteries.
So it's biological, not just mechanical.
Absolutely. Think of it like this. The cascade begins with what we call endothelial dysfunction, which is essentially damage to the inner lining of the valve. This sets the stage for the infiltration of lipids, such as oxidized LDL and phospholipids, into the valve tissue.
So it really is like plaque building up, but on a heart valve instead of an artery wall, like valve cholesterol.
In a simplified way, yes. This lipid accumulation then triggers a profound inflammatory response. The valve tissue starts recruiting various immune cells, including monocytes, T cells, and mastocytes, leading to a localized inflammatory reaction.
Inflammation. That sounds active.
Very active. This inflammation then culminates in a complex fibrocalcific response. During this stage, collagen is deposited, leading to fibrosis, essentially scarring and stiffening of the valve. But here's the truly remarkable part. Valvular interstitial cells, or VICs, which are resident cells in the valve, actually differentiate phenotypically into osteoblasts.
Osteoblasts, like bone cells.
The very same types of cells that actively produce bone matrix proteins in our skeletons. This leads to the deposition of calcium hydroxyapatite crystals, forming hard, bone-like material directly on the valve leaflets. It's a cellular transformation that the valve tissue is literally trying to turn itself into bone.
That's absolutely remarkable, the body's own cells effectively turning valve tissue into bone. Are there genetic factors that predispose individuals to this kind of cellular change?
Yes, there's a growing understanding of genetic predispositions, which highlights the complexity. Genetic polymorphisms, variations in our DNA involving things like the vitamin D receptor, the estrogen receptor in postmenopausal women, interleukin-10, and apolipoprotein E4 have all been linked to the development of calcific AS.
So genetics can play a role.
Definitely. Furthermore, a strong familial clustering of cases with trileaflet valves has been reported from Western France, suggesting a significant inherited component in some populations. So, while it's an active process, genetics can definitely load the dice for some individuals.
And what about traditional risk factors we usually associate with heart disease, like high cholesterol or blood pressure? Do they play a role in AS progression, or is it entirely separate from that?
They absolutely do, and this is another crucial connection. Many of the same traditional atherosclerotic risk factors that contribute to coronary artery disease and stroke are also strongly associated with the development and progression of calcific AS.
Like what specifically?
This includes hypertension, elevated low-density lipoprotein, LDL, cholesterol, lipoprotein (LEPA), diabetes mellitus, smoking, chronic kidney disease, and metabolic syndrome.
The whole list.
Pretty much. In fact, a Canadian observational cohort study found that hypertension, diabetes mellitus, and dyslipidemia alone accounted for approximately one-third of the population attributable risk for severe AS. This highlights how systemic health issues contribute directly to the health of our heart valves.
That makes sense. It's all connected.
It is. It's also important to understand the concept of aortic valve sclerosis. This is a condition where there's focal thickening and calcification of the leaflets, but it's not severe enough to cause actual obstruction of blood flow.
So like pre-stenosis.
Kind of, but here's the key implication. Even this milder form, sclerosis, is associated with an excess risk of cardiovascular death and myocardial infarction among persons aged over 65. Approximately 30% of individuals aged over 65 years exhibit some degree of aortic valve sclerosis, indicating it's a very common precursor or an early manifestation of the degenerative process.
30%, that's common.
Very. The rate and extent to which this sclerosis progresses to full-blown valve obstruction, or stenosis, can vary significantly among individual patients, which makes predicting the future course challenging and underscores the need for monitoring.
That's a good point about the variability. Now, let's circle back to bicuspid aortic valve disease. It seems like a distinct entity within AS, given it's a congenital defect. Can you give us a deeper dive into its specific characteristics and why it matters as a cause of AS?
Sure. Bicuspid aortic valve disease is indeed the most common congenital heart valve defect, affecting a notable 0.5% to 1.4% of the population, with a clear male predominance, typically 2 to 4 males for every female.
Born with 2 leaflets instead of 3.
Exactly. The inheritance pattern appears to be autosomal dominant with incomplete penetrance, meaning you can carry the gene but not necessarily develop the condition, though there's been some discussion about a potential X-linked component given its prevalence in patients with Turner syndrome. Approximately 10% of first-degree relatives of an affected individual will also have BAV disease.
So there's definitely a genetic link there.
A strong one. While a single gene defect hasn't been identified to explain the majority of cases, mutations in genes like NOTCH1, GATA5, GATA4, endothelial nitric oxide synthase, and NKX2.5 have been implicated in some families, showing the genetic complexity involved.
So it's not just the valve itself that's different, but there's a genetic predisposition, and it can affect other parts of the aorta, right? This goes beyond just the valve.
Precisely. A common and critically significant associated issue is aortopathy, meaning disease of the aorta itself, not just the valve. Medial degeneration, which is a weakening of the aortic wall, with ascending aortic aneurysm formation occurs commonly, affecting about 30% to 40% of BAV patients.
Aneurysm. That's serious.
It is. Aortic coarctation, which is a narrowing of the aorta, is less frequent but can also occur. What's crucial is that patients with BIE disease generally have larger aortas than those with comparable tricuspid aortic valve disease. And this aortopathy actually develops independently of how severe the valve lesion's hemodynamic impact is.
So the aorta is weak regardless of the valve function.
Essentially, yes. The aorta is inherently weaker in these patients. The directional shear forces dictated by the specific anatomic configuration of the bicuspid valve also appear to influence how this aortopathy expresses itself. For instance, enlargement of the ascending aorta along its greater curvature is most often associated with the right-left cusp fusion, which is the most common bicuspid variant. These patients are at a higher risk for aneurysm formation and/or dissection, which can be life-threatening events.
Wow. So BAV is a package deal almost?
It can be. Furthermore, a BAV can sometimes be a component of even more complex congenital heart disease, occurring with or without other left heart obstructing lesions, such as those seen in Schoen's complex. So it's a congenital condition with widespread implications for the entire aortic system, not just the valve itself.
Are there other obstructions we should briefly mention?
Yes, just quickly, it's worth mentioning that besides valvular AS, there are other forms of obstruction to left ventricular outflow. These include hypertrophic obstructive cardiomyopathy, where the heart muscle itself is thickened and obstructs outflow, and supravalvular AS, where the obstruction is above the valve in the aorta.
Different locations for the blockage.
Exactly. These conditions are typically differentiated from valvular AS based on a thorough cardiac examination and, most definitively, by Doppler echocardiographic findings. So it's about making sure we pinpoint the exact location of the blockage.
It's clear that AS isn't just one thing, but a complex interplay of genetics, lifestyle, and congenital factors. That's a truly professional-level understanding of the why. Now, let's turn to what happens inside the heart as this obstruction progresses. What's the heart's first response to this growing resistance, and how does that response change over time?
Right. When there's an obstruction to the left ventricular LV outflow, as occurs in aortic stenosis, the LV is immediately faced with a fundamental challenge. It has to generate significantly higher pressure to eject blood into the aorta.
It has to work harder to push the door open.
Precisely. Initially, especially if the obstruction develops gradually over many years, the LV responds in a remarkably adaptive way by developing concentric hypertrophy. This means its muscular walls thicken considerably and symmetrically inwards.
And how does that thickening actually help the heart initially? It sounds like it's just working harder. Is it beneficial?
It is, initially. It's a clever compensatory mechanism. And this is a core principle of cardiac physiology, often described by the Laplace relation. Conceptually, think of the stress on the heart wall like the tension in a balloon. That tension is related to the pressure inside and the sides of the balloon, but it's reduced by how thick the balloon's wall is.
Okay. Thicker wall, less stress for giving pressure.
Exactly. So by dramatically increasing its wall thickness, the heart can actually reduce its systolic wall stress back towards a more normal level, even though it's generating much higher pressure to push blood through that narrowed valve. This incredible adaptation means that a large pressure gradient across the aortic valve can exist for many, many years without any reduction in the overall cardiac output or any significant dilation of the left ventricle. The heart is maintaining its performance by getting stronger and thicker.
So that sounds like a good thing, a heroic adaptation, but you mentioned the word initially. What's the pivot point here? When does this adaptation start to become a problem, becoming maladaptive instead of helpful?
That's the crucial turning point, and it's a progression from adaptation to eventual failure. Eventually, this excessive hypertrophy becomes maladaptive.
Maladaptive.
Yeah.
So harmful.
Yes. At this stage, the LV systolic function begins to decline, often due to what we call afterload mismatch, meaning the heart muscle can no longer efficiently overcome the resistance of the narrowed valve without becoming exhausted. Simultaneously, abnormalities of diastolic function.
That's the relaxing and filling part.
Right. The heart's ability to relax and fill with blood also progress. This leads to elevated LV and diastolic pressure, even if the ejection fraction, which is a common measure of how well the heart pumps, is still preserved. Ultimately, and this is a significant and often irreversible consequence, myocardial fibrosis develops.
Scarring of the heart muscle.
Exactly. Scarring, making it stiffer, less compliant, and less efficient at pumping.
So how do doctors define when obstruction is actually severe?
In terms of defining severity, our source gives us concrete, measurable criteria that professionals use. Severe obstruction to LV outflow is generally defined by a mean systolic pressure gradient across the valve greater than 40 mmHg, assuming the cardiac output is still normal.
Okay, a gradient over 40.
Or, alternatively, it's defined by an effective aortic orifice area of less than 1 centimeter north or less than 0.6 centimeters per square meter of body surface area in a normal-sized adult. To put that into perspective, it's less than approximately 1/3 of the normal orifice area. These precise numbers are critical for diagnosis and treatment decisions.
And how does this affect the heart's overall output, the amount of blood it manages to pump out, especially during activity?
Well, while cardiac output is often maintained at rest in the early stages, once AS becomes severe, it typically fails to rise normally during exercise. This is a key indicator of functional limitation and often brings patients to attention.
They get breathless faster.
Right. Also, a vigorous atrial contraction is quite important for effectively filling the stiffened left ventricle. So if a patient develops conditions that disrupt this, like atrial fibrillation, where the atria quiver chaotically,
AFib.
or atrioventricular dissociation, where the atria and ventricles aren't coordinating properly, it can cause a rapid and significant progression of symptoms because the heart loses that critical atrial kick.
So the heart is struggling more and more. What happens in the very late stages when the disease is far advanced and the heart is truly failing?
In the very late stages, the contractile function of the left ventricle deteriorates significantly due to the persistent afterload excess. This means the heart simply can no longer push blood out effectively, causing both the cardiac output and the LV aortic pressure gradient to decline.
So the pressure difference actually goes down.
It can, yes, because the pump is failing. As the LV struggles, pressures start to back up throughout the circulatory system. The mean left atrial, LA, pulmonary artery, PA, and right ventricular RV pressures all begin to rise, leading to fluid backup and congestion.
Like a traffic jam in the circulation.
Exactly. If the patient also has coexisting epicardial coronary artery disease, which is common in older AS patients, the LV performance can be even further compromised due to a lack of blood flow to the heart muscle itself. It's also important to note that even with a seemingly normal ejection fraction, stroke volume, the amount of blood pumped with each beat, can be reduced in patients with significant hypertrophy and a relatively small LV cavity. This is a subtle but important point.
You mentioned low flow, low gradient AS before. Can you remind us what that is and why it's tricky?
Sure. This brings us to that specific and diagnostically challenging scenario. Low flow, low gradient aortic stenosis. This is defined by a stroke volume index of less than 35 millimol per square meter, combined with a mean pressure gradient across the valve of less than 40 mmHg.
So low flow out, but the pressure drop isn't that high.
Right, and this can occur whether the LV systolic function is reduced or even still normal. It presents both a significant diagnostic and therapeutic challenge because it's difficult to ascertain the true severity of the stenosis and, therefore, the best course of action without further investigation. Is the valve really tight, or is the pump just weak?
The heart muscle itself, the myocardium, must be under immense strain with all this increased workload. What does this mean for its oxygen requirements and the risk of ischemia, even without blocked arteries?
You're absolutely right. This is another critical piece of the puzzle. The hypertrophied left ventricle has markedly increased myocardial oxygen requirements simply because it's a larger, harder working muscle.
Needs more fuel.
Exactly. Adding to this, even if there's no obstructive coronary artery disease, meaning the arteries supplying the heart muscle itself are clear, the coronary blood flow to the heart muscle is impaired. This makes the heart particularly vulnerable to ischemia, a lack of oxygen, especially under conditions of excess demand, like during exercise or stress.
Why is the flow impaired even with clear arteries?
Several reasons. The capillary density is reduced relative to the increased wall thickness, meaning fewer tiny blood vessels for a bigger muscle. There are increased compressive forces on the coronary vessels within the thickened muscle during contraction, literally squeezing them. And finally, the elevated left ventricular end diastolic pressure further reduces the coronary driving pressure, making it harder for blood to perfuse the muscle, especially the inner layers.
So the muscle is starved for oxygen even with open supply lines?
Effectively, yes. The subendocardium, the innermost layer of the heart muscle, is especially vulnerable to ischemia through this mechanism.
It's a remarkable journey the heart takes, from heroically adapting to ultimately struggling under the increasing load. That gives us a truly detailed understanding of the how. But what does this entire progression feel like for the person living with AOS? When do patients typically start experiencing symptoms, and what are those key signs they might notice that would make a doctor suspicious?
Right. Aortic stenosis is indeed an insidious disease, often progressing silently for years. It's rarely clinically significant until the valve orifice narrows considerably, typically to about 1 centimeters less.
So you can have it for a while and not know.
Absolutely. What's surprising to many is that even severe AS can exist for many years without producing any symptoms at all. This is due to the hypertrophied left ventricle's initial ability to maintain performance, as we just discussed. However, for patients with bicuspid aortic valve disease, they often develop significant valve dysfunction and start experiencing symptoms 1 to 2 decades earlier than those with age-related calcific AS.
So a younger presentation might point towards BAV.
Often, yes.
So it's often a silent progression for a long time. But once symptoms do appear, are there typical patterns or groups of symptoms that doctors look for? I hear there's a classic triad.
Precisely. Once symptoms emerge, we look for what's famously known as the classic triad of symptomatic aortic stenosis: exertional dyspnea, angina pectoris, and syncope.
Shortness of breath, chest pain, fainting.
You got it. Exertional dyspnea, or shortness of breath with physical activity, is the most common. It results primarily from an elevation of the pulmonary capillary pressure, which is caused by elevated left ventricular diastolic pressures, secondary to impaired relaxation and reduced LV compliance. Essentially, the stiff, hypertrophied heart isn't filling properly, causing fluid to back up into the lungs, making it hard to breathe with effort.
Back pressure causing breathlessness. Makes sense.
Angina pectoris, which is chest pain, usually develops somewhat later in the disease course. It reflects that imbalance we talked about between the increased myocardial oxygen requirements of the hypertrophied heart muscle and a reduced availability of oxygen.
Even without blocked coronary arteries sometimes.
Yes, though it's important to note that coronary artery disease often coexists, especially in patients over 65, complicating the picture. Finally, syncope, or fainting, is often exertional, meaning it happens during or after physical activity.
Why fainting?
It can result from a decline in arterial pressure caused by vasodilation in exercising muscles, coupled with an inadequate vasoconstriction in non-exercising muscles, all in the face of a fixed cardiac output that the stenotic valve can't increase to meet demand. Or it can be caused by a sudden fall in cardiac output brought on by an arrhythmia.
So those are the main 3 warning signs. What about symptoms that occur even later when the disease is very advanced and the heart is truly failing?
Right. In the very advanced stages when cardiac output is severely compromised, patients might experience marked fatigability, pervasive weakness, peripheral cyanosis, a bluish discoloration of the extremities, and even cardiac cachexia, which is severe wasting of the body.
So really systemic effects.
Yes. These signs of a low cardiac output are typically not prominent until quite late in the course. Symptoms of overt left ventricular failure, such as orthopnea, meaning shortness of breath when lying flat, paroxysmal nocturnal dyspnea, PND, which is waking up gasping for air at night, and pulmonary edema, where the lungs fill with fluid, also usually appear only in the advanced stages.
Classic heart failure symptoms.
Exactly. Furthermore, severe pulmonary hypertension, which can lead to right ventricular failure, causing systemic venous hypertension, and a large liver, atrial fibrillation, AF, and tricuspid regurgitation, TR, are typically late findings in patients with isolated severe AS.
What if someone has other valve problems at the same time? Does that change things?
Good question. It definitely can. Coexisting valve disease can influence or even mask the symptoms of AS, making diagnosis trickier. For example, if aortic stenosis and mitral stenosis coexist.
So narrowing of 2 valves?
Right. The reduction in blood flow or cardiac output caused by the mitral stenosis can actually lower the pressure gradient across the aortic valve. This effectively masks many of the typical clinical findings of AS, making it seem less severe than it is.
Interesting.
Conversely, if a patient has concomitant aortic regurgitation, a leaky aortic valve, the higher blood flow rates across the valve can actually increase the transaortic pressure gradient, making the AS seem more severe on measurements than it might otherwise be. So the interplay of valves is crucial.
That makes perfect sense. The heart is a system, and issues with one valve can certainly impact the presentation of another. Now, here's where it gets really interesting for a clinician. What can a physical examination tell us about aortic stenosis? What can a doctor hear and feel with just their hands and a stethoscope?
A great deal, actually, and it's a hallmark of clinical diagnosis. Starting with the pulse and blood pressure, the heart rhythm is generally regular until very late in the course of the disease. If atrial fibrillation is present earlier, it often suggests the possibility of associated mitral valve disease. Hypertension is quite common among older adults with AS. However, in the late stages, when the stroke volume declines, the systolic pressure may fall, and the pulse pressure can narrow, indicating the heart is truly struggling to eject blood.
The pulse itself feels different.
Often, yes. The carotid arterial pulse is often very characteristic. We look for what's called pulsus parvus et tardus, which means the pulse rises slowly to a delayed peak and feels small and delayed.
Small and slow.
Exactly. A thrill or an anacrotic shudder, which is a distinct vibration, may even be palpable over the carotid arteries, more commonly on the left side. However, a crucial point. In elderly patients, the stiffening of the arterial wall can sometimes mask this important physical sign, making it harder to detect, so you can't always rely on it.
Good caveat. What else can you feel?
In many patients, the A wave in the jugular venous pulse is accentuated. This specific finding results from the diminished distensibility of the right ventricular cavity, which is caused by the bulging, hypertrophied interventricular septum, essentially pushing into the right ventricle.
Okay, a sign of pressure backup.
Right. Moving to the heart's impulse, the left ventricular impulse may be displaced laterally in the later stages of the disease as the heart becomes larger. A double apical impulse, often with a palpable S4 heart sound, can sometimes be appreciated, especially if the patient is positioned in the left lateral recumbent position. A systolic thrill, that vibration we mentioned, may also be present at the base of the heart, usually to the right of the sternum, particularly when the patient leans forward or in the suprasternal notch, indicating turbulent blood flow.
Fascinating how much information you can gather just by touch and observation. Now, let's talk about auscultation, the sounds of AS. What are the key sounds a doctor listens for with a stethoscope that signal this condition?
Auscultation is truly central to diagnosing AS clinically. An early systolic ejection sound.
A click?
Yes, a click right after the first heart sound. It's frequently audible, particularly in children, adolescents, and young adults who have congenital bicuspid aortic valve disease. However, this sound typically disappears as the valve becomes calcified and rigid, so it's often absent in older adults with calcific AS.
Okay, so the click goes away as it gets worse sometimes.
Right. As aortic stenosis increases in severity, the left ventricular systole, the period of contraction, may become prolonged. This causes the aortic valve closure sound, A2, to no longer precede the pulmonic valve closure sound, P2. They might become synchronous, or the aortic valve closure might even follow the pulmonic valve closure, leading to what we call paradoxical splitting of S2.
The second heart sound splits abnormally.
Exactly. It tells you the left heart is working harder and longer. The sound of aortic valve closure itself, A2, can be heard most frequently in patients with AS who still have pliable valves. As the valve calcifies and stiffens, the intensity of this sound diminishes, often becoming quite soft or inaudible, which can be another sign of severity.
Softer A2 means stiffer valve, usually.
Generally, an S4 heart sound is frequently audible at the apex of the heart. This reflects the presence of left ventricular hypertrophy and an elevated left ventricular end diastolic pressure, indicating the heart is struggling to fill properly against a stiff wall. An S3 heart sound, on the other hand, generally occurs much later in the course of the disease, usually when the left ventricle dilates and its systolic function becomes severely compromised, indicating outright heart failure.
S4 early, S3 late.
Typically. And then, of course, there's the murmur, the quintessential sound of aortic stenosis. It's described as an ejection or mid-systolic murmur.
Systolic, so during the heart's contraction.
Right. It commences shortly after the S1 heart sound, increases in intensity, reaching a peak mid-systole, and then decreases in intensity, a pattern we call crescendo-decrescendo. Think of it like a diamond shape when you graph its sound intensity over time.
Where do you hear it best?
It's typically heard best at the base of the heart, most commonly in the second right intercostal space. Critically, it's transmitted upward along the carotid arteries, which is a classic finding, as the turbulent blood flow radiates. Occasionally, it can also be transmitted downward into the apex, where it might be confused with the systolic murmur of mitral regurgitation. This phenomenon is known as the Gallivardin effect.
And does loudness equal severity?
Usually, but not always. In almost all patients with severe obstruction and preserved cardiac output, the murmur will be at least a grade in intensity, meaning it's quite loud and easily heard. However, and this is important for clinicians, in patients with only mild obstruction, or paradoxically, in those with very severe stenosis, along with heart failure and low cardiac output, where the stroke volume and thus the transvalvular flow rate are significantly reduced, the murmur may actually be relatively soft and brief.
So a quiet murmur doesn't rule out severe A if the heart is failing.
Exactly. This can sometimes make severe disease harder to detect if one relies solely on murmur intensity, emphasizing the need for comprehensive assessment.
That's an incredibly detailed and vivid description that really brings the physical exam to life. It shows us how much information can be gathered by a skilled clinician. But of course, modern medicine gives us even more powerful tools to visualize and measure what's happening inside the heart. So let's talk about the lab tests and imaging. Beyond what we hear and feel, what does the lab work and imaging reveal when someone has AS?
Right, let's start with the electrocardiogram, or ECG. In most patients with severe aortic stenosis, the ECG will show signs of left ventricular hypertrophy, meaning the heart muscle wall is thickened.
Okay, thickened muscle on ECG.
In more advanced cases, you'll often see ST segment depression and T-wave inversion, which is a pattern we refer to as LV strain, particularly in standard leads, S and AVL, and in the left, precordial leads. However, it's important to understand that there isn't a precise correlation between the ECG findings and the hemodynamic severity of the obstruction.
So it's suggestive, but not definitive.
Exactly. This means the absence of ECG signs of LV hypertrophy doesn't necessarily exclude severe obstruction, and conversely, systemic hypertension, which is common, can coexist and contribute to the development of hypertrophy, complicating the picture. So it's a good screening tool, but not definitive on its own.
So ECG is a helpful first step, but not the definitive answer. What about echocardiography, which I understand is often considered the gold standard for diagnosing AS and evaluating its severity?
You're absolutely right. Echocardiography is invaluable, truly the gold standard for diagnosis and assessment. The key findings on a transthoracic echocardiogram include visible thickening, calcification, and a reduced systolic opening of the aortic valve leaflets, along with visible left ventricular hypertrophy.
You can actually see the valve not opening well.
Yes. For congenitally bicuspid valves, an eccentric closure of the aortic valve cusps is a characteristic sign that helps differentiate it. While transesophageal echocardiography, where the probe goes down the throat, can display the obstructed orifice extremely well, it's not routinely required for an accurate characterization of AS in most cases, given the quality of transthoracic images.
What about measuring the severity? How does echo do that?
The real power of echocardiography for AS comes from Doppler measurements. This allows us to precisely estimate the valve gradient, which is the pressure difference across the valve, and critically the aortic valve area by measuring the transaortic velocity of blood flow.
Velocity tells you how narrow it is.
Right. Based on these measurements, we define severe AS as the valve area less than 1 centimeters Nors, moderate AS as 1 to 1.5 centimeters Nors, and mild AS as 1.5 to 2 centimeters Nors. For aortic valve sclerosis, where there's thickening and calcification but not severe obstruction, the jet velocity is less than 2.5 meters per second, corresponding to a peak gradient of less than 25 millimeter HJ.
And it tells you about the heart muscle function, too.
Definitely. Echocardiography also provides crucial information about LV function. LV dilation and reduced systolic shortening reflect impairment. There's also robust experience using longitudinal strain, a more sensitive measure, to characterize earlier, subtle changes in LV systolic function even before a decline in ejection fraction can be appreciated, which is important for identifying problems early. Doppler indices of impaired diastolic function are also frequently observed, showing the heart's difficulty relaxing.
So it gives a really complete picture.
It does. Beyond assessment of the AS itself, echocardiography is incredibly useful for identifying any coexisting valvular abnormalities, for differentiating valvular AS from other forms of LV outflow obstruction, and for measuring the aortic root and proximal ascending aortic dimensions, which is particularly important for patients with BAV disease due to their associated aortopathy.
You mentioned low-flow, low-gradient AS as a particularly tricky diagnostic challenge. How does echocardiography help in that specific complex scenario?
Good question. For patients with low-flow, low-gradient severe AS with a reduced ejection fraction, meaning they have severe AS symptoms, but the numbers don't quite add up due to their poor LV pump function, dobutamine stress echocardiography is extremely useful.
Giving the heart a chemical stress test.
Right. Dobutamine is a medication that temporarily increases heart contractility, and by giving it, we can see if there's a flow reserve, if the heart can increase its stroke volume by 20% or more. This allows us to accurately assess the true severity of the stenosis. If the gradient goes up significantly as flow increases, we know the stenosis is truly severe.
Well, it unmasks the severity.
Exactly. However, a crucial caveat for professionals, for patients with severe AS, valve area less than 1 centimeter inertial, but a relatively low mean gradient, less than 40 millimeter HG, despite a normal ejection fraction, what we call paradoxical low-flow, low-gradient severe AS. These patients are often hypertensive. In this specific setting, the butane stress echocardiography is generally not advised,
Why not?
because optimizing their systemic blood pressure control should be the first step. High blood pressure can artificially lower the gradient, confounding the readings. So control the BP, then repeat the echo.
Got it. What about other imaging like CT or MRI?
CT is playing an increasing role. When there's persistent uncertainty regarding the severity of AS, particularly in patients with reduced cardiac output where the standard Doppler measurements might be misleading, quantitative analysis of the amount of aortic valve calcium using chest-computed tomography, or CT, can be very helpful.
Measuring the calcium itself.
Right. Beyond diagnosis, CT imaging is increasingly becoming the imaging method of choice for planning transcatheter aortic valve implantation, or TVI. It allows for precise assessment of aortic valve morphology and the surrounding structures, which is critical for safe and effective TVI.
So CT is key for TAVI planning.
Absolutely. And finally, cardiac magnetic resonance, or CMR imaging, is an active area of investigation. It's being explored for its ability to screen for the presence of myocardial fibrosis with late gadolinium enhancement in patients with severe AS, which can give us crucial insights into irreversible heart damage and help guide prognosis.
Seeing the scarring with MRI. Interesting. So we've got high-tech imaging. What about a more basic tool like a chest X-ray? What can that tell us about AS, if anything?
The chest X-ray can offer some subtle clues, though it's less definitive for AS severity compared to echo or CT. For many years, it may show no or very little overall cardiac enlargement, as the LV hypertrophy initially keeps the heart size within normal limits.
So it can look normal early on.
Often, yes. However, this hypertrophy without dilation can sometimes produce some rounding of the cardiac apex in the frontal projection and a slight backward displacement in the lateral view. A dilated proximal ascending aorta may also be seen along the upper right heart border in the frontal view. Crucially, aortic valve calcification may be discernible in the lateral view, but it's usually much more readily apparent and precisely evaluated on fluoroscopic examination or by echo.
What's the main takeaway from X-ray then?
The absence of valvular calcification on fluoroscopy in adult is a strong indicator that severe valvular AS is not present, making it a useful exclusion tool in some cases. If you don't see calcium, severe AS is less likely in an adult.
Now, for the most invasive diagnostic tools, cardiac catheterization and angiography. Given all the other powerful non-invasive options we've just discussed, when are these still necessary? They seem less common now.
They are less common. Invasive assessment of AS using right and left-sided heart catheterization is performed infrequently now, primarily because of the excellent non-invasive tools we just discussed, which provide comparable information with less risk.
But not never.
Not never. It can still be very useful when there's a discrepancy between the clinical findings and the non-invasive imaging results, where there's significant diagnostic uncertainty and you need definitive pressure measurements directly from inside the heart. There has been some concern raised about the risk of cerebral embolization when attempting to cross the aortic valve for direct measurement of LV pressures, which is a factor considered.
So when would you definitely use catheterization?
Despite its infrequent general use, catheterization is still useful in three distinct categories of patients. First, in patients with multivalvular disease, it helps define the precise hemodynamic role played by each valvular deformity, which is critical for planning complex operative treatment.
To sort out which valve is causing which problem.
Exactly. Second, in young asymptomatic patients with non-calcific congenital AS, catheterization can help define the exact severity of the obstruction. This is important because operation, or percutaneous aortic balloon valvuloplasty, PVV, may be indicated even without symptoms if severe AS is confirmed.
For younger patients without calcium.
Right. And third, it's used in patients where there's a suspicion that the obstruction to LV outflow might not be at the level of the aortic valve itself, but rather at the sub- or supravalvular level, where other imaging might not be as clear.
And what about checking the coronary arteries?
Yes. Coronary angiography is indicated to screen for coexisting coronary artery disease in appropriate patients with severe AS who are being considered for surgical or transcatheter valve intervention. This can be performed invasively at the time of catheterization for hemodynamic assessment or non-invasively using CT techniques. The decision-making regarding the need for coronary artery revascularization at the time of aortic valve intervention is always individualized based on the patient's overall condition and the extent of CAD.
Got to check the pipes before fixing the valve, basically.
Essentially, yes. Ensure a holistic approach.
These diagnostic tools paint a remarkably detailed picture, helping us not just diagnose, but also understand the progression, which leads us to the natural history of AS. It sounds like AS is a progressive disease with serious consequences. What's the typical course, and how quickly does it advance once symptoms actually appear?
You're absolutely right. Aortic stenosis is unequivocally a progressive disease. When we look at the mortality profile, death in patients with severe AS most commonly occurs in the 7th and 8th decades of life.
So older adults typically.
Typically, our sources, based on historical data from patients before surgical treatment was widely available, give us a sobering timeline. The average time to death after the onset of specific symptoms was around 3 years for angina pectoris,
3 years with chest pain,
0.3 years for syncope,
3 years with fainting,
zero point 0.2 years for dyspnea,
2 years with shortness of breath.
and a mere 1.5 to 2 years for overt heart failure.
Wow, that's fast once heart failure sets in.
Extremely fast. This truly emphasizes the rapid decline once symptoms become apparent. In fact, over 80% of patients who die with AS had symptoms for less than 4 years, highlighting how quickly the disease can become fatal once it manifests clinically.
That's a very clear and alarming timeline. What about the risk of sudden death in these patients? Is it a common first sign, or does it usually occur once symptoms are already present?
That's an important distinction for both patients and clinicians. While sudden death, presumably from an arrhythmia, did occur in 10% to 20% of adults dying with valvular AS. The critical point is that most of these sudden deaths occurred in patients who had already been symptomatic.
So symptoms usually come first.
Usually, yes. Sudden death as the first manifestation of severe AS is actually very uncommon in asymptomatic adult patients, with an estimated risk of only about 1% per year. So while it's a possibility that always needs to be considered, it's far more likely to occur once the disease has declared itself with other symptoms, which is why symptom monitoring is so crucial.
Okay, so about 1% per year risk of sudden death if you're truly asymptomatic with severe AS.
That's the estimate, yes. In terms of the overall disease progression rates, calcific AS follows a predictable, albeit variable, pattern. On average, there's an annual reduction in the valve area of about 0.1 centimeters per year.
Getting tighter by 0.1 centimeters per year.
On average. Concurrently, we see annual increases in the peak jet velocity, averaging around 0.3 meters per second, and annual increases in the mean valve gradient, averaging about 7 millimilli-Hg. These numbers illustrate a consistent, measurable progression of the obstruction over time, underscoring why regular monitoring with echocardiography is so crucial for these patients, even when asymptomatic.
That's a clear picture of how serious AS can become and how quickly it can progress once symptoms appear. The good news is we have increasingly sophisticated treatment options available. Let's dive into those because this is where modern medicine truly transforms the prognosis. So what are the treatment approaches for aortic stenosis? Do we start with medications, or is intervention the primary path?
That's a fundamental question, and here's the crucial aha moment. Medical treatment for aortic stenosis is primarily supportive, not curative. It does not slow the progression of AS itself.
So pills won't fix the valve narrowing.
Correct. Therefore, intervention, meaning a procedure to fix or replace the valves, is indeed the primary path once the disease becomes severe and symptomatic.
What about managing things medically before intervention? Any specific advice?
Yes. For patients with severe AS, defined by a valve area less than 1 centimeter sac, certain activities should be avoided. Strenuous physical activity and competitive sports should be avoided, even in the asymptomatic stage, because they can precipitate adverse events like sudden death or syncope.
So take it easy, basically.
Yes. Careful hemodynamic management is also key. Care must be taken to avoid dehydration and hypovolemia, as a significant reduction in cardiac output can be dangerous in these patients due to their fixed outflow obstruction. Keep fluid levels stable.
What about medications people might already be on for other heart conditions, like high blood pressure or coronary artery disease? Are they safe, or do they need to be stopped if AS is present?
Generally, medications used for the treatment of hypertension or coronary artery disease, including beta blockers and ACE inhibitors, are typically safe for asymptomatic patients with preserved left ventricular systolic function.
So you can usually continue those.
Usually. Nitroglycerin can also be helpful in relieving angina pectoris in patients who have coexisting coronary artery disease. However, it's crucial to note that certain therapies which might seem logical to prevent calcification have been proven ineffective.
Like what?
Neither HMG-CoA reductase inhibitors, commonly known as statins, nor inhibitors of the renin-angiotensin-aldosterone system have been shown to slow the rate of AS progression.
So statins don't help the valve itself.
Correct. While statins are important for primary and secondary prevention of atherosclerotic cardiovascular disease events, their use in AS should be driven by those broader ASCVD considerations, not AS progression itself. Lastly, the need for endocarditis prophylaxis, which is a preventative antibiotic before certain procedures, is very restricted for AS patients, only recommended if they have a prior history of endocarditis.
So medical management is supportive, but not a cure. That leads us to surgical aortic valve replacement, or SAVR, which has traditionally been the gold standard. When is this open heart surgery actually indicated for these patients?
Right, SAVR. For asymptomatic patients with calcific AS and severe obstruction, the initial approach is careful observation. They should be followed closely for the development of symptoms and with serial echocardiograms for any evidence of deteriorating left ventricular function.
Watchful waiting.
Exactly. However, once certain criteria are met, operation becomes unequivocally indicated. The clear indications for operation, as outlined in Table 261-2 from our source, are as follows. First and foremost, symptomatic severe AS.
If you have symptoms in severe AS, you need surgery.
Pretty much. Patients with severe AS, defined by a valve area less than 1 centimeter or less than 0.6 centimeters per square meter of body surface area, who are symptomatic, should undergo operation promptly, typically within 1 to 3 months after symptom onset, because their prognosis declines rapidly.
Don't wait too long after symptoms start.
Definitely not. Second, asymptomatic patients with severe AS who show declining left ventricular systolic function, specifically an ejection fraction below 50%, should also proceed to surgery, as this indicates the heart is starting to fail even without symptoms.
Weakening pump means surgery, even without symptoms.
Correct. Third, if a patient with asymptomatic moderate or severe AS is already being referred for other concomitant cardiac surgery, such as coronary artery bypass grafting, they should also have AVR at the same time.
Fix everything at once if you're already having heart surgery.
Makes sense, right? Less risk than 2 separate operations. And fourth, if a patient with severe AS is undergoing surgery for a dilated ascending aorta, particularly if its maximal dimension is greater than 5.5 centimeters, valve replacement should occur due to the risk of rupture. For aneurysm disease itself, operation is sometimes recommended at smaller aortic diameters, around 4.5 to 5.0 centimeters, for patients with a family history of an aortic catastrophe, or those exhibiting rapid aneurysm growth, defined as more than 0.5 centimeters per year.
What's the operative risk for this kind of surgery today? And has there been much debate about operating on asymptomatic patients, given that earlier natural history data showed a lower sudden death risk for that group?
Good questions. For patients without heart failure, the operative risk for isolated SAVR, meaning just the valve replacement without other procedures, is remarkably low, around 2% according to our source.
Only 2% risk for just the valve. That's pretty good.
It's a testament to surgical advancements. However, this risk does increase with age and with the need for concomitant procedures like other heart valve surgery or coronary bypass grafting. And you hit on a key point. The indications for SAVR in asymptomatic patients have indeed been the subject of intense debate.
Why the debate?
This is largely because surgical outcomes in selected patients have continued to improve substantially, making the risk-benefit calculation more favorable, especially for those who are otherwise good candidates.
Oh.
Maybe intervening earlier is better than waiting for symptoms if the surgery is safe enough.
So are there times when surgery might be considered, even if someone is asymptomatic and doesn't meet those strict criteria?
Yes, there are several relative indications where surgery can be considered. These include an abnormal response to treadmill exercise, where even if they don't have classic symptoms, their heart isn't performing adequately under stress.
Failing the stress test.
Right. Rapid progression of AS is another, especially if urgent access to medical care might be compromised in the future. Very severe AS, defined by an aortic valve jet velocity greater than 5 meters, or a mean gradient greater than 60 mmHg, coupled with a low operative risk, can also trigger consideration.
Just really, really tight valve, even without symptoms yet.
Exactly. And finally, excessive left ventricular hypertrophy in the absence of systemic hypertension might also be a relative indication, suggesting the heart is working too hard and suffering structural changes even before symptoms appear.
So exercise testing can actually play a practical role in identifying these asymptomatic patients who might benefit from earlier intervention. That's a practical insight.
Yes, exactly. Exercise testing can be safely performed in asymptomatic patients with AS, and it provides objective data. And what's interesting is that as many as 1/3 of them will actually show signs of functional impairment during the test, even if they don't perceive symptoms in their daily lives.
So the test uncovers hidden limitations.
It can, yes. This provides objective evidence for intervention. There is even a small randomized controlled trial that looked at early surgery versus conservative care for asymptomatic patients with very severe AS, defined by those very high velocities or gradients we mentioned, or a valve area of 0.75 centimeters ready. This study showed that the rate of operative death or death from cardiovascular causes during follow-up was significantly reduced with early surgery.
Early surgery helped in that very severe group.
It did. In the conservative care group, the cumulative incidence of sudden death was 4% at 4 years and a more concerning 14% at 8 years, really underscoring the potential benefits of earlier intervention in this very specific high-risk asymptomatic subgroup.
What about those challenging subgroups, like the low-flow, low-gradient patients? How does surgery stack up there?
Yes. While clinical decision-making is relatively straightforward for patients with normal flow and high-gradient severe AS, it becomes far more complex for certain challenging subgroups. For patients with low flow, low gradient severe AS, and a reduced left ventricular ejection fraction, often referred to as D2.
The weak pump, low gradient group.
Right. Perioperative mortality rates for surgery are high, ranging from 15% to 20%, and evidence of LV dysfunction often persists even after a technically successful operation. Long-term postoperative survival in these patients is closely correlated with their preoperative LV function.
So the outcome depends a lot on how weak the heart was beforehand.
Very much so. Nevertheless, given the even worse prognosis for such patients if they are treated medically, valve replacement is usually advised, particularly if dobutamine stress echocardiography demonstrates that flow reserve, showing the heart has some capacity to recover. Patients in this very high surgical risk group are now often treated with TAVI, though robust randomized controlled trial data specifically for this subpopulation are still somewhat lacking.
And what about the low flow, low gradient group, but with a normal ejection fraction, the paradoxical group?
That's D3. The management of patients with this paradoxical low-flow AS is also very challenging. Our sources indicate that outcomes are improved with surgery, or TVI, compared to conservative medical care for symptomatic patients in this category. But more research is needed to fully guide individualized therapeutic decisions. It's also critical to remember that in patients where severe AS and coronary artery disease coexist, the relief of the AS combined with coronary revascularization can lead to striking clinical and hemodynamic improvement.
Since many patients with calcific AS are elderly, are there specific preoperative considerations for them beyond just the heart itself? This is important for a holistic approach.
Absolutely, because many patients with calcific AS are indeed elderly, particular attention must be directed to assessing the adequacy of their hepatic, renal, and pulmonary function before recommending AVR. These are critical factors for overall surgical risk and recovery.
Got to look at the whole patient.
Exactly. It's important to emphasize, though, that age alone is not a contraindication to SAVR for AS. The perioperative mortality rate depends to a substantial extent on the patient's overall preoperative clinical and hemodynamic state. Assessment of frailty, which goes beyond just age and comorbidity, is also a critical component of the pre-procedural evaluation, as it's a strong predictor of outcomes.
Frailty matters a lot.
A huge amount.
Yeah.
For AS patients who are not at low operative risk, treatment decisions are not made by a single physician, but by a multidisciplinary heart team. This team includes representation from general cardiology, interventional cardiology, multimodality imaging specialists, cardiac surgery, and other subspecialties as needed, including geriatrics, ensuring a holistic, expert approach.
The heart team approach.
Essential for complex cases.
Yeah.
For older adult patients undergoing SAVR, the 10-year survival rate is approximately 60%, which highlights the long-term benefits possible with this procedure.
That brings up another important point, the choice of valve prosthesis. Patients can get either a biological valve, which is tissue-based, or a mechanical valve, which is artificial. What are the key trade-offs there that patients and doctors need to consider?
This is a critical shared decision-making point, and it's a big one for patients. The recommendations regarding the type of valve prosthesis, biological or mechanical, require a careful weighing of the trade-offs. Biological valves have a limited durability.
Tissue valves wear out eventually.
They do. Approximately 30% of them will show primary valve failure by 10 years, which then requires either re-replacement surgery or a valve-in-valve TAVI procedure. For this reason, biological valves are generally favored for patients aged over 65 years, where their expected lifespan aligns better with the valve's durability. You don't want the valve to wear out too quickly.
Okay, so tissue for older patients generally. What about mechanical?
On the other hand, mechanical valves are very durable, essentially lasting a lifetime. However, they come with a significant requirement. Patients need lifelong anticoagulation with vitamin K antagonists, like warfarin, to prevent blood clots on the valve.
Blood thinners for life.
Right, and this carries its own risks, with approximately 30% of patients developing hemorrhagic complications as a consequence of this treatment over time. So the decision is highly individualized, factoring in patient age, their expected longevity, their lifestyle, and their personal preferences regarding reoperation versus lifelong anticoagulation.
So durability versus blood thinners, basically.
That's the core trade-off. An observational study even showed that for patients under 55 years old, receiving a biological prosthesis was associated with an excess hazard of death over 15 years compared to a mechanical valve, suggesting mechanical might be better for younger patients with long life expectancies. Finally, homograft AVR, which uses a human donor valve, is usually reserved for specific cases, primarily aortic valve endocarditis, where infection is a concern.
I've also heard of something called the Ross procedure. Is that still an option for AS, and for whom?
The Ross procedure, yes. It's a highly specialized and technically complex surgical procedure. It involves replacing the diseased aortic valve with the patient's own pulmonic valve, which is called an autograft, and then implanting a homograft, a donor valve, in the native pulmonic position to replace the removed pulmonic valve.
Swapping the patient's own valves around.
Essentially, yes. It's considered for young or middle-aged adult patients, but only when both surgical and institutional expertise are readily available due to its complexity and the need for two-valve procedures. While it offers benefits like avoiding lifelong anticoagulation, late postoperative complications can include aortic root dilation, aortic regurgitation, and right ventricular outflow tract obstruction, so it's not without its own set of challenges.
So those are the surgical options. What about percutaneous aortic balloon valvuloplasty, or PABV? I understand it's often more of a bridge than a definitive solution for adults.
That's a very accurate way to put it for adults. PBV is indeed the preferred procedure for children and young adults with congenital non-calcific AS, where the valve tissue is more pliable and can be stretched.
Better for stretchy, non-calcified valves.
Exactly. However, for adults with severe calcific AS, it is not recommended as a definitive therapy. The reasons are clear. It has a very high restenosis rate, meaning the valve narrows again rapidly, with 80% restenosis typically occurring within 1 year, and there's also a risk of procedural complications.
So the fix doesn't last long with calcium?
Not at all. On occasion, it has been used successfully as a temporary bridge to either operation or TAVI, particularly in patients with severe LV dysfunction and shock, to stabilize them before a definitive, more durable procedure. Interestingly, it is performed routinely as a first step during the TAVI procedure itself to create an orifice of sufficient size for the new transcatheter valve to be inserted.
And that brings us to what many consider the game changer in IS treatment, transcatheter aortic valve implantation, or TAVI. What impact has this had on the landscape of AS treatment?
TAVI has truly revolutionized the treatment landscape for aortic stenosis. It surpassed SAVR for AS treatment in the United States back in 2016, marking a significant shift in practice.
More TVIs than surgeries now in the U.S.
That's right. What's truly remarkable is that TAVI is now available to symptomatic patients across all surgical risk spectrums, from prohibitive and high risk to intermediate and even low risk, based on the consistently favorable results seen in a series of landmark randomized controlled trials reported over the past decade.
So it's not just for the sickest patients anymore. Even low-risk surgical candidates can get TVI.
Correct. The data supports its use even in low-risk patients, showing similar or sometimes even better outcomes for certain endpoints compared to surgery. This is a monumental shift for patients and clinicians alike.
That's incredible. And how does it actually work? What are the components involved?
Its application in asymptomatic AS patients is even currently under active investigation, pushing the boundaries further. Most commonly, TVI is performed using one of two main systems, either a balloon expandable valve or a self-expanding valve, both of which incorporate a pericardial bioprosthesis.
So they are tissue valves like the surgical ones?
Yes, derived from animal tissue. The procedure is most frequently undertaken via the transfemoral route, meaning through an artery in the groin, which is minimally invasive. However, other access routes have been used when the femoral artery is not suitable, including transalveopical, subclavian, carotid, and ascending aortic.
Different ways to get the valve in?
Exactly. As mentioned, aortic balloon valvuloplasty is typically performed as a first step under rapid pacing to create an orifice of sufficient size for the new transcatheter prosthesis to be delivered. Procedural success rates exceed 95% in appropriately selected patients, and valve performance characteristics are excellent over 5 years. Longer-term durability assessment is still ongoing, which is a key area of research as TVI is used in younger patients.
So we still need more long-term data on how long TVI valves last compared to surgical ones.
That's the main question, especially for younger patients. But the 5-year data looks very good.
That truly sounds transformative. This technology has clearly extended valve replacement to patient groups who previously had very few options, effectively expanding access to life-saving treatment.
It has indeed. The outcomes achieved with this transformative technology have been very favorable and have allowed for the extension of aortic valve replacement to groups of patients who were previously considered at high or even prohibitive risk for conventional surgery due to their age or comorbidities. This is a monumental leap in cardiac care.
But it's not for everyone, right? There are still limitations.
Correct. It's important to acknowledge that some patients, even those at prohibitive or high surgical risk, are still not candidates for TAVI. Their specific comorbidity profile and overall frailty might make the procedure inappropriate or too risky. In these challenging cases, the multidisciplinary heart team is specifically charged with making these complex decisions, ensuring the best possible and most ethical outcome for the patient.
What about using TAVI for valves that have already been replaced surgically but wore out?
Ah, yes. The use of these transcatheter devices for treating patients with structural deterioration of existing bioprosthetic aortic valves, a procedure known as valve-in-valve TAVI, has increased sharply over the past 5 years. This offers a less invasive alternative to reoperative valve replacement for patients whose initial tissue valve is worn out.
TAVI inside a failed surgical valve. Clever.
It is. The technology has also been increasingly applied to patients with bicuspid aortic valve disease, despite the fact that patients with this specific anatomy were often excluded from the initial landmark randomized controlled trials. This speaks to the expanding confidence and experience with TAVI.
This truly underscores the personalized nature of modern medicine. It's not a one-size-fits-all approach, but a careful, considered decision for each unique individual, weighing so many factors.
Yeah.
So for a patient who needs valve replacement, what are the absolute key factors that guide the choice between SAVR and TAVI? This is where true professional-level decision-making comes into play.
This is truly where the art and science of medicine meet, as you said. The overarching principle, as emphasized in our source, is that decision-making should be shared with the patient and their entire heart valve team.
Shared decision-making is key.
Absolutely. This involves a thorough discussion of both SAVR and TAVI, with a meticulous risk assessment being absolutely central to the process. Our source, particularly Table 261.3 and Figure 261-7, provides a detailed framework for this complex decision.
Let's break that down, starting with age and life expectancy. How do those factors sway the decision towards one procedure or the other?
Okay. For younger patients, generally those under 65 years old with a longer life expectancy, SAVR is still often favored.
Why surgery for younger folks?
The reason is that long-term data, specifically 20-year outcomes for SAVR bioprosthetic valves, are more robust and well-established. And of course, mechanical valves offered by SAVR are very durable, essentially lasting a lifetime. This offers less uncertainty about valve durability for patients who are expected to live many more years. Our current guidelines recommend SAVR for patients under 65 precisely because there's still scant randomized controlled trial data on TVI outcomes in this younger group.
So durability certainty favors surgery for the young. What about older patients?
Conversely, TAVI is favored for older patients, typically those over 80 years old, who generally have fewer expected remaining years of life. The balance between expected longevity and valve durability varies continuously across age groups. And critically, if a patient has a very limited life expectancy, perhaps less than 1 year post-TVI, then palliative care might be the most appropriate path.
That makes perfect sense. What about the valve anatomy itself? Does the specific shape or calcification of the aortic valve play a role in which procedure is chosen?
Absolutely. Valve anatomy is a very significant factor. SAVR is generally favored if the patient has a bicuspid aortic valve. While TAVI is increasingly used off-label for BA, SAVR may still offer a better, more precise repair, especially for complex BAV anatomy.
Surgery might handle BAV better sometimes.
Often, yes. SAVR is also favored for cases with subaortic, meaning below the valve, calcification, or for rheumatic valve disease, which often involves complex anatomical distortions that are difficult for TVI to navigate. Additionally, if the patient has a very small or a very large aortic annulus, which is the ring at the base of the valve, SAVR allows for surgical root enlargement, which can accommodate a larger prosthesis and reduce patient-prosthesis mismatch.
So surgery offers more flexibility for tricky anatomy. When is TAVI favored anatomically?
TAVI is typically favored for calcific trileaflet AS, which is the most common anatomy and the one most studied and optimized for TAVI implantation, making it a smoother procedure in those cases.
And what if a patient has a strong preference for one type of prosthetic valve over another? Does that come into play in this highly personalized decision?
Patient preference for the type of prosthetic valve is crucial for shared decision-making. If a patient prefers a mechanical or surgical bioprosthetic valve, SAVR would be favored, as TAVI currently only offers bioprosthetic options.
TAVI is tissue only.
Right. Also, if there's significant concern for patient prosthesis mismatch, where the new valve might be too small for the patient's body size, then surgical annular enlargement during SAVR might be considered to optimize the outcome. Conversely, TVI is favored if the patient prefers a bioprosthetic valve and if there's a favorable ratio of their expected life expectancy to the valve's known durability. TVI can also sometimes provide a larger effective valve area than a same-sized SAVR.
Beyond the valve itself, what if a patient has other concurrent heart conditions? How does that influence the choice between SAVR and TAVI?
Concurrent cardiac conditions are major determinants. SAVR is favored if the patient has aortic dilation that requires surgical correction, or severe primary mitral regurgitation, or severe coronary artery disease requiring bypass grafting, or septal hypertrophy needing a myectomy, or even atrial fibrillation that can be addressed concomitantly during SAVR.
So if other things need fixing surgically, surgery makes more sense.
Generally, yes. These are all conditions that directly benefit from open heart surgery. On the other hand, TAVI is favored for patients with severe calcification of the ascending aorta, often referred to as a porcelain aorta, which makes surgical clamping extremely risky and difficult.
Can't clamp a rock-hard aorta safely.
Exactly. If the patient has irreversible severe LV systolic dysfunction or severe mitral regurgitation due to annular calcification, indicating severe global heart disease, then palliation might be favored, as intervention may not offer significant benefit in such advanced, complex cases.
So it's not just about the heart then, is it? What about other non-cardiac conditions that might complicate either procedure?
Non-cardiac conditions are indeed very important and can significantly tip the scales. TAVI is often favored for patients with severe lung, liver, or renal disease, or those with mobility issues, as these conditions significantly increase the risk associated with a sternotomy and the longer recovery period typically associated with SAVR. TAVI offers a much less invasive approach.
KVI better for sicker patients with other organ problems.
Often. Conversely, if a patient's symptoms are primarily due to non-cardiac conditions, or if they have severe dementia or moderate to severe involvement of two or more other organ systems, indicating poor overall health and limited benefit from intervention, then palliation might be favored. In such cases, the burden and risk of intervention may simply outweigh the potential benefits.
Frailty assessment has become a major part of evaluating patients for surgery these days. How does that factor into the SAVR versus TAVR decision?
Frailty is a critical component of risk assessment, and it's much more than just chronological age. If a patient is not frail or has very few measures of frailty, SAVR would typically be favored, assuming all other factors are equal.
Fit patient, surgery is fine.
TAVI, however, is favored for patients where frailty is present, but is likely to improve significantly after the TAVI procedure due to its less invasive nature and quicker recovery. But if a patient is severely frail and their frailty is unlikely to improve even after TAVI, meaning their overall health is too compromised, then palliative care becomes the favored option.
So TAVI for the frail but potentially recoverable, palliation for the severely frail.
That's a good term.
So it's about balancing the estimated risk of each procedure. How is that calculated and how is it used in the decision-making process?
The estimated risk of both SAVR and TAVI is central. SAVR is favored if its risk is considered low and the TAVI risk is high, perhaps due to specific anatomical challenges. Conversely, TAVI is favored if its risk is low to medium, while SAVR carries a high to prohibitive risk.
How is high risk defined?
This high to prohibitive SAVR risk is often defined by a Society of Thoracic Surgeons STS score greater than 8%, or if the patient has more than 2 frailty measures, or involvement of more than 2 major organ systems, or any procedure-specific impediment that makes SAVR particularly risky for them. If the SAVR risk is truly prohibitive, typically over 15%, or if the patient's estimated post-TAVI life expectancy is less than 1 year, then palliation is favored.
It seems like there are also specific anatomical or logistical reasons that might make one procedure impossible or extremely difficult. Can you give us some examples of those procedure-specific impediments?
Yes, these are crucial considerations that can dictate the path forward. SAVR is favored, because TAVI is impeded, if the valve anatomy, the annular size, or a low coronary ostial height precludes TVI. These anatomical features might make it impossible or unsafe to implant a transcatheter valve without blocking the coronary arteries.
Can't block the heart's own arteries.
Absolutely not. Similarly, if the patient's vascular access doesn't allow for transfemoral TVI, for instance, due to severe peripheral artery disease and other access routes are also not feasible or too risky, then SAVR would be the preferred surgical route. Previous cardiac surgery with at-risk coronary grafts or previous chest irradiation can also make TAVI more complex or risky, thus favoring SAVR.
So sometimes TVI just isn't technically possible.
Correct. Conversely, if valve anatomy, annular size, or coronary ostial height precludes any intervention, meaning neither SAVR nor TAVI is safe or feasible, or if vascular access prevents transfemoral TAVI and other routes are also not feasible or too risky, then palliative care might be the only viable option.
This all boils down to the patient's individual goals of care and their personal preferences and values. How does that discussion factor into this very complex decision-making process? This seems to be the ultimate personalization of medicine.
This is truly the most crucial element, bringing together all the medical data with the human aspect. If a patient values less uncertainty about valve durability and wants to avoid repeat intervention, or if they prioritize a lower risk of permanent pacemaker implantation, SAVR might be favored.
If long-term certainty is key, surgery might be better.
Similarly, if their strong preference is for maximal life prolongation, symptom relief, and improved long-term exercise capacity and quality of life, and they accept a longer hospital stay and more pain in the recovery period, SAVR would align with those goals.
What kind of patient preferences favor TAVI?
TAVI might be favored if the patient accepts the potential uncertainty about long-term valve durability and the possibility of a repeat intervention down the line. They would also accept a potentially higher risk of permanent pacemaker implantation. If their strong preference is also for life prolongation, symptom relief, and improved exercise capacity and quality of life, but they prefer a shorter hospital stay and less post-procedure pain, TVI would be the better fit.
Faster recovery might be the deciding factor.
It often is. Lastly, if life prolongation is not an important goal for the patient, or if they wish to avoid futile or unnecessary diagnostic or therapeutic procedures, or they want to avoid the procedural stroke risk or the possibility of needing a cardiac pacemaker, then palliative care aligns with their values. This comprehensive discussion with the heart team, the patient, and their family is what truly personalizes the treatment plan.
A collaborative, informed choice. That's the goal. This truly underscores the personalized nature of modern medicine. It's not a one-size-fits-all approach, but a careful, considered decision for each unique individual, weighing so many factors and always with the patient at the center. So we've taken a remarkable journey today. We started by understanding the significant global burden of valvular heart disease, especially aortic stenosis, and how its prevalence shifts between different income levels and age groups.
Right, from RHD globally to degenerative disease here.
We then delved into its complex origins, moving beyond simple wear and tear to the intricate interplay of genetics, inflammation, and traditional risk factors, truly understanding it as a modern professional would.
Seeing it as an active biological process, not just passive aging.
We explored how this insidious condition impacts the heart, from initial valiant adaptation to eventual struggle and failure. We then moved into the detailed methods used to diagnose it, from subtle physical exam findings to the cutting-edge imaging and invasive techniques,
allowing us to truly see and measure the disease precisely.
And finally, we navigated the array of sophisticated treatment options available today, from medical management to the nuanced choices between traditional surgery and transformative transcatheter approaches.
What's fascinating here, and a key aha to take away, is how our understanding of something like aortic stenosis has evolved from just seeing it as a simple mechanical blockage to recognizing it as a disease with complex inflammatory and genetic underpinnings.
That active disease process you described.
Exactly. This deeper understanding has, in turn, led to truly transformative treatments like TAVI, which are revolutionizing how we approach heart valve disease. It's a testament to how medical science continues to evolve, allowing us to offer increasingly tailored and effective care.
And as we see TAVI increasingly applied to younger patients and those with bicuspid aortic valves, and with continuous innovation pushing the boundaries, it raises an important question for all of us. Will surgical aortic valve replacement one day become a procedure of the past, or will its unique advantages always ensure its place in treating this complex disease?
That is the multi-million-dollar question right now.
What stands out to you about how these medical advancements could reshape the future of heart care? We hope this deep dive has given you a truly well-informed shortcut into the complex and fascinating world of aortic stenosis. Keep seeking those aha moments.